So thank you, Gihan, for asking me to do this presentation, and please accept my apologies for not being there in person. So I will just highlight some of the differences between the ICD-10 and the ICD-11. And Gihan specifically said that this would benefit the trainees, but I hope that the psychiatrists will gain something from this as well. Okay, so before I talk about the ICD and ICD-10 and 11, I will just touch on the concept of diagnosis of psychiatric illness and then also comment a little bit about the DSM-5. So just to understand how we diagnose conditions, if we look at COVID, we know that we do a PCR test to diagnose COVID, and the diagnosis is actually done by identifying the viral fragments. So it is a etiological diagnosis. We also know that people with COVID can present with different sort of sets of symptoms. So the classical sort of fever and cough and loss of smell. Then at the other end, there can be people who go into respiratory failure. Some people are almost asymptomatic. Now, we don't diagnose COVID 1, 2, 3, or whatever it is based on the symptom clusters. We diagnose it based on the etiology, and even the subtypes are based on the viral mutations. And this difference in the diagnosis, the basis for the diagnosis, the first one is the etiological diagnosis, which we use for COVID, and in psychiatric illness, the use of symptoms. This is something that is very important for trainees to understand and think about this when we go through the new categories in the ICD-11. So the validity of psychiatric illness, I think this is one of the landmark articles, and I especially suggest the trainees to access and read this. It's not a very long article. It's by Robbins and Goose, and if you want, you can access it online. So they published this article in 1970, and they just talked about how can we set up a diagnosis for a psychiatric illness. What are the criteria to say that this disorder actually exists? So the first thing, like I said, is the clinical symptoms and maybe the epidemiology. So if something is an illness, then it has to have a common epidemiology. The second thing is whether there are any laboratory studies which support the diagnosis. And sadly, we don't have a lot still. The third one is delimitation from other disorders. So if we say that schizophrenia is an illness, then it can't be also similar to a host of other illnesses. Then the data that we get from follow-up studies, in the course of the illness, it has to stay the same, probably, the diagnosis and also the prognosis and the support from the family studies. So the families have to have clusters of the same kind of illness if it is genetically transmitted. So then let's look at the ICD, the overview. So the first difference that is noted is a slight change in the name. But one thing that we must remember is that the ICD is not just mental and behavioral disorders. ICD is the Bible of all the illnesses known to mankind. It is the coding used all over the world. So chapter 6 is just one chapter in a huge book, whereas the DSM-5 is just about mental and behavioral disorders. So the first chapter in ICD-11 compared to the ICD-10 is neurodevelopmental disorders. That is because they are now taking a lifespan approach, starting from the illnesses seen early in life. And though we are very familiar with the ICD-10, and the ICD-10, the first chapter is organic disorders. Now, why is there such a big change in the new ICD-11? So the reason for the organic disorders being the first chapter in the ICD-10 is because at the time that it was formulated, there was this very strong belief in the diagnostic hierarchy. So that means if you have symptoms of two of these sets of conditions, if you have psychotic symptoms together with organic illnesses, then the ones that are higher up in the hierarchy trumps. So you diagnose organic disorder instead of psychotic disorder. Similarly, if you have psychotic symptoms and affective symptoms together, commonly schizophrenia and depressive symptoms, you diagnose schizophrenia rather than an affective disorder. Now, I think this diagnostic hierarchy is really not very much accepted now, and that is the reason why they have done away with the system that is used in the ICD10 and use the ICD11 lifespan approach, which is similar to that seen in the DSM-5. Now, I won't go into details in each category because there is a lot to talk, but just if you look at it, so the first thing that you see is this big set of conditions in almost at the end of the ICD-10 is there in the first set of under neurodevelopmental disorders. Some name changes like mental retardation, which I think carries a lot of negative connotations, has been named as disorders of intellectual development. There's an autism spectrum disorder, so it's almost like a dimensional way of looking at it instead of the categories described in ICD-10. I'm sure there are a lot of other changes, but I won't go into details about that. So let's look at probably the most important condition for us, schizophrenia, which is now called schizophrenia or other primary psychotic disorders. If you look at the subcategories, there isn't a lot that has changed really. But there is a slight change in the way we diagnose. Again, in the ICD-10, there are two groups of A to D and E to H. I know the trainees generally call them major and minor criteria, similar to the rheumatic fever, although it's not referred to as such. And this so-called major criteria or symptoms A to D is really the Schneider's first rank symptoms. And if you have even one symptom, you can diagnose schizophrenia. Now that again has been disregarded, and no symptom is more important than others. So there is a set of 7 symptoms and 2 must be present. So there is no hierarchy of symptoms in the ICD-11. Again, similar to the DSM. The duration hasn't changed. It is 1 month. And interestingly, there are no subtypes of schizophrenia. So I think it makes life a little bit easier for the trainees. They don't have to identify subtypes at exams, I guess. The other important thing is catatonia has been given as a separate category. Now, it used to be called catatonic schizophrenia, subtype of schizophrenia in the ICD-10, and interestingly, even in the DSM, it's still, although it's like a subcategory in that psychosis section. Now, what is the reason for giving catatonia a separate category? I would suggest that trainees have a look at this book, Catatonia by Fink, and it really spells out the etiological basis for catatonia. If you can't access the book, you may be able to access this article which we wrote some time ago, and in the introduction we have summarized the reasons. So the book on catatonia was written in 2003, our article was done in 2013, so that means this talk about catatonia being not part of schizophrenia has been going on for a long time. Just sort of quickly going through the reasons. So one is that catatonia is seen more in mood disorders than in schizophrenia, and also associated with organic condition. So that is one reason for saying it's not a subtype of schizophrenia. Then the classical symptoms of delusions and hallucinations are not characteristic of catatonia. It responds to treatment with benzodiazepines and ECT very well. So the thought is that it is due to a deficiency of cortical GABA. So again, I would like the trainees to think of the diagnostic validity criteria given by Robbins and Goose and see that catatonia really fulfills all those criteria for a separate disorder. Next is the category of mood disorders. Again, there is a fairly significant difference between ICD-10 and 11. ICD-10 has a category called manic episode. So that they have given subtypes with the intensity varying from hypomania to mania with psychotic symptoms. So the thinking behind one category called manic episode and another one called bipolar affective disorder is that these are two different conditions. That's why they put it as two different diagnostic categories. In fact, the ICD10 says single episodes have been distinguished from bipolar and other multiple episodes because substantial proportion of patients have only one episode of illness. Now, this is what they knew in the early 90s, and now we know that this is not correct. We know that 90% of people who have a manic episode will have another episode, and that there is really no separate illness called a single manic episode. And therefore, this has been now done away with. So there is bipolar type 1 and there is bipolar type 2, and that is similar to the DSM. Again, I'm not going to go through the subtle differences in the diagnostic criteria because I can't do that in the time that is given. But for trainees and for the trainers also, please go through them. There are significant changes within these categories. The next big category in the ICD-10 is anxiety, stress-related, and somatoform disorders. So this actually encompasses almost all non-psychotic and non-mood disorders which are commonly seen. And I think this is influenced by the concept of psychotic disorders and neurotic disorders. So this category in the ICD-10 is what we used to call neurotic disorders. This has been broken down into several different categories. So the first one is anxiety and fear-related disorders. Just a couple of things worth highlighting. So social anxiety disorder, not social phobia, because I think, again, because of the negative connotations. And interestingly, conditions which we thought are more seen in children have been included. So in the anxiety disorder category doesn't differentiate between childhood onset disorders and adult disorders. So separation anxiety disorder and selective mutism is included in this category. But I think one of the most important changes is to see that obsessive compulsive or related disorders is now recognized as being separate from the other anxiety disorders. This again, I know although we used the ICD-10 for many years, there was a lot of talk about OCD being different, and that is based on a lot of neuroimaging. We now know the sort of the neuro circuitry that sort of happens when people are having OCD, and also supported by a lot of genetic studies. So this is a reflection of the increasing understanding we have about this condition, and that's why it is a separate disorder. But interestingly, hypochondriasis is now classified under OCD. This was under somatoform disorders in the ICD-10. Again, I think these are things that I have certainly discussed with the trainees even when we were using the ICD-10 about how similar people with hypochondriasis, the way they present are to people who have OCD. So they have this obsessional thought that they have an illness. AIDS phobia is a classical sort of condition where they believe that they have AIDS. And then the anxiety builds up, and then they go to a doctor and request an AIDS test. And that is almost like the ritual, and that releases the anxiety. Unlike the OCD, where you wash hands 10 times a day, this is probably more long drawn. But then after several days or several weeks, again, the anxiety begins to build in, and then again they go to a doctor. So interestingly, they have recognized that the psychopathology in hypochondriasis is different. And the importance, I think, of this is that probably the way we treat hypochondriasis has to be different, because we right now under the ICD-10, we group it together with somatoform disorders and use almost like a psychodynamic way of dealing with these conditions. Similarly, I think understandably, body dysmorphic disorder also has been classified under obsessive compulsive disorders, as well as a couple of other conditions. Right. The next sort of interesting change is in this category in the ICD-10, which is calls from section 50 to 59. It's almost like a group of unrelated disorders grouped together. It's called behavioral syndromes associated with physiological disturbance, and it's eating, sleep, and sexual dysfunction. I remember even in the mental health module, one unfortunate teacher has to teach these three conditions together, and it's very difficult to sort of say why they are related and why they are under one category. So feeding and or eating disorder is there in the ICD-11 under chapter 6 as a new category. But what is important and interesting to note is all the sleep disorders have been taken out of chapter 6. Chapter 6 is basically our ICD, the mental and behavioral disorders, and they have made a new chapter and put it in as sleep-wake disorders. What is the reason for this? So in the ICD-10, the non-organic sleep disorders were under the mental and behavioral disorders, and the organic sleep conditions went into the neurology chapter. I remember Professor Samarasinghe teaching us, saying that, in the future, when they start discovering the organic basis for conditions, they will start taking it out of the mental and behavioral disorders and start putting it into neurology. I think it's already happening. And what the ICD states is the new ICD-11 chapter on sleep-wake disorders will acknowledge that sleep disorders are a distinct area of practice requiring independent clinical attention. So basically, I think what the ICD is saying is psychiatrists are not specialists. It's a different subspecialty. We know there are already sort of experts in sleep conditions, and there are sleep laboratories and so on. So that has been taken away from the psychiatrists in the ICD-11. But interestingly, in the DSM-5, it is still there as sleep-wake disorders. The next important change is that the conditions related to sexual health, the entire thing has been taken out into a separate chapter 17 as well. So that means, again, that is not there under the mental and behavioral disorders. Again, especially for the trainees, I suggest that they go and access this article because it really gives the disorders related to sexuality and gender identity in ICD-11, revising ICD-10 classification based on current scientific best clinical practice and human rights considerations. So that is the new thing that has come in, that has changed over the past 25 years. A lot of awareness and a lot of lobbying and human rights movements have resulted in this change. So again, if you look at it broadly, in the ICD-10, everything was under sexual dysfunction. In the ICD-11, the only thing left to the psychiatrist is paraphilic disorders. Everything else has been taken into chapter 17, a separate condition, and it's called conditions related to sexual health. And again, I think there are sort of, new specialists almost in sexual health emerging. So that's been taken away from the psychiatrist in the ICD, but not in the DSM, interestingly. The DSM-5 condition called sexual dysfunctions, which is similar to almost to the ICD-10 exists. One of the major changes in the sexual dysfunction conditions is gender incongruence. So you have to understand that the ICD-10 was done in the early 1990s. And at that time, gender identity disorder was classified under disorders of adult personality and behavior. It is similar to sort of what society was in the early 1970s. I think maybe in DSM-2, we know that homosexuality was there and that was removed. And gender identity, if you identified yourself as being different to whatever your birth assigned sex is, you were considered to have a mental and behavioral disorder classifiable in the ICD-10. That has been taken out completely, and you only can be diagnosed if there is an incongruence experienced. And it's the same in the DSM-5, it's called gender dysphoria. Now you might question as to why this still remains in here. Why didn't they take this out completely? And my understanding or my reading of the condition is that if you think of the Western world, medical insurance plays a very big part in how you pay for your accessing your healthcare. And if you go to a doctor and you're charged, you can get reimbursed from your insurance company, but to do that, you need to have a diagnosis. So if people with gender dysphoria want to seek help and want to be able to claim it under medical insurance, they can't do it unless it is there as a diagnosis. So I think that is the reason why it is still here. Then there's of course, a big category of disorders due to substance use or addictive behaviors. Again, I'm not going to go into sort of details. Please look at it in detail. There are a lot of important changes. I will just sort of tell you basically there are two conditions. One, gambling disorders, which was under habit and impulse disorders in ICD10, which has been brought here. Again, kind of a recognition that the sort of these are the behavioral addictions that you don't have to become addicted. You don't have to use a substance. Sometimes even behaviors can lead to addictions, and that's why the gambling disorder has been put in here. And of course, reflecting the new changes in society, gaming disorder has been included here as well. The next major sort of category is called neurocognitive disorders. This is the organic disorder condition which is in ICD-10, and the new name change is sort of the same as what we see in the DSM-5. So the conditions of delirium, amnestic disorder, and dementia are still there, but there is a new condition called mild neurocognitive disorders. Again, I know we have been sort of discussing this for many years, although it was not there in the ICD-10. Increasing evidence that there are people who have some impairment of their cognition, which doesn't amount to dementia, but which is more than age related, and the recognition of a separate condition. The other interesting thing to note, if you're comparing with the DSM, is that in the DSM, the word dementia is not used. I think it is also because of the sort of negative connotations. People don't like to be diagnosed with dementia. So I think they call it major neurocognitive disorder with Alzheimer's disease. That's the way they word it. But in the ICD, the term is still used. Interesting category here. Mental and behavioral disorders associated with pregnancy, childbirth, or the puerperium. I know we've had many sort of discussions and even arguments as to whether this consists of a separate condition, because in the ICD it wasn't, and trainees used to always ask, can we diagnose puerperal psychosis or do we need to diagnose schizophrenia? And again, I think the reason probably, if we go through all the criteria for validating a diagnosis, we can kind of justify there is a separate etiology. It's related to the pregnancy. The signs and symptoms sometimes can be the same as in schizophrenia, but the prognosis is very different. And also there are social reasons for having new categories, because in a way this sort of provides for developing new services as well. So that's why there is probably a different separate condition. And the last two sort of subsections in the ICD-11 are two conditions which I couldn't really find a corresponding thing in ICD-10. One is called psychological or behavioral factors affecting disorders or diseases classified elsewhere, and secondary mental or behavioral symptoms associated with disorders or diseases classified elsewhere. I think we used to use the condition adjustment disorder or secondary organic conditions for most of these. Just to understand what can be classified here, it seems to me that a lot of conditions that we see in our liaison psychiatry unit in the general hospitals are included here. So these are examples given in the ICD-11 itself. A woman with bulimia nervosa and type 1 diabetes mellitus who skips insulin doses as a way to avoid weight gain that would otherwise be caused by her binge eating. Depressive symptoms interfering with rehabilitation following surgery. So we know that surgeons send us and say, look, this person is not doing what they should do. So now we know that this comes under this new condition. Pathological denial of need for surgery in a patient with cancer. Again, not uncommon referrals. Hostile pressured behavior contributing to heart disease. And the last one is interesting, the presence of maladaptive health behaviors that adversely affect the manifestation, treatment, or course of a disorder. Example, overeating and lack of exercise. So that means we can kind of classify quite a few people in this category. So what I've done is sort of gone through in a very broad way, comparing the ICD-10 and the 11 and a little bit of comments from the DSM-5, especially for the trainees, and I think the trainers can probably help them look at changes in specific diagnostic criteria, especially for the common conditions. There is a lot that you can see, subtle changes, bipolar 1, bipolar 2, even in schizophrenia, there's a lot to see. Look at these conditions and be familiar with the reasons for the changes and understand the basis for making these new disorders, because these, somebody didn't just sit down and write these conditions. People had to submit submissions for arguing for a new condition with a lot of evidence of published literature. So understand why, especially where major changes have been made in things like sexual dysfunction and so on. What is the reasoning for doing this? I think there is a potential for a lot of exam questions in this very big group. And also, just remember the first slide where I showed you the COVID diagnosis, which is etiologically based. Go through the ICD-11 and see how many of them are actually etiologically based diagnosis, because that is where we will eventually have to head towards. Thank you.
Thank you so much, Madam, for the beautiful lecture. I'm sure you will have a lot of questions on this topic from Madam. Unfortunately, we are running out of time, so we can have just a couple of questions before we winding up this session.
The first part of the question was about this dysmorphophobia, where I thought it was a delusional state and I prescribed antipsychotics. But now, if you say it is OCD, then antipsychotics don't have a place, and I have to replace it with a 5-HT. Now, I may be wrong. Can you please correct me?
Yes, Usha, I think dysmorphophobia is on a spectrum, and there is a lot of evidence that it responds well to SSRIs. So I think the first line of treatment now recommended is SSRIs. But having said that, there are people whose dysmorphophobia may be delusional in nature. So yes, you're right. I think SSRI should be tried as first line.
There's one question from the participants online from Dr. Kalyana Rodrigo. Could you please comment on the dimensional approach to personality disorders in ICD-11? That's the question.
Yes, I think that is beyond my expertise really. We do know that there was a big attempt to sort of classify conditions as dimensional in the ICD, in the DSM, and I'm not sure whether they succeeded, but my reading is that it is still more categorical than dimensional. I don't know whether you agree with that.
I like to make a comment, Shavindra Dias. It's quite interesting when you see the DSM, ICD 9, 10, and 11, how the social perception has influenced our diagnostic categorization, which philosophically, to me, poses the question, are we really dealing with illnesses in a futuristic point of view?
Yes, I think my comment is really to refer back to the COVID slide. If we didn't have diagnostic tests to diagnose COVID, the social perspective will come in. And they will say, you know, these people with asymptomatic illness don't have COVID and don't sort of tell them to isolate and so on. But because there is a diagnostic etiological basis for diagnosing, there is no social perspective. In psychiatric illness, at least the so-called organic sort of, you know, conditions where we can find a basis, until we do that, the social thing will creep in. The other thing is, of course, which I didn't comment on, is the kind of conditions that we deal with. I think that is what Dr. Rodrigo is also saying, is on a dimension, and even anxiety, where do you draw the line and what is abnormal? So that is the difficulty, and that's where I think the social perspective comes in and pressurizes to call, you know, almost move the bias to what becomes pathological.